Good morning, dear student. I will be discussing about SGLT2 when we should eat early for the benefit of patient of type 2 diabetes mellitus. What is the endocrine perspective of SGLT2 inhibitor? Why this molecule should be used and what are the benefits of this particular molecule? So updates on empagliflozin in the management of type 2 diabetes mellitus from the cardiovascular benefit to the glycemic efficacy. We all know that the various SGLT2 molecules are available in the market, which includes the canagliflozin, empagliflozin, remogliflozin, sotagliflozin. Various molecules has been available, but in Indian market, there are 3 to 4 molecules has been available. And there are various studies which has been done with this SGLT2 molecule and the beneficial effect has been demonstrated. Some of the studies which has been done with the empagliflozin, they have shown that molecule is having a significant cardiovascular benefits, not only in terms of the reduction of the cardiovascular mortality, but there is reduction of the various event like congestive cardiac failure or the impairment of the renal failure has been prevented with this particular molecule. So this is the outline of my presentation. Cardiovascular risk in the patients of type 2 diabetes mellitus. Empagliflozin in cardiovascular risk factor, hypertension and obstructive sleep apnea. Empagliflozin in type 2 diabetes mellitus and atherosclerotic cardiovascular disease with various cardiovascular disease manifestation. Effect of empagliflozin on heart failure outcome, heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. We are aware that recently 2 studies has been published. So the effects of this particular study has been discussed in the today's discussion. Clinical consideration of anti-diabetic agent, that is of SGLT2 inhibitor and DPP4 inhibitor, effect of empagliflozin on insulin requirement and pharmacoeconomics will be discussed. Atherosclerotic cardiovascular disease in patients of type 2 diabetes mellitus. So atherosclerotic cardiovascular disease affects almost 1 out of 3 patients with diabetes mellitus worldwide. This has been done from the capture studies and other studies. Coronary artery disease is the major cardiovascular disease burden in type 2 diabetes mellitus patient, which affect almost 1 in 6 patients with type 2 diabetes mellitus, 2 in 3 patients with congestive heart failure, and 1 in 3 patients with the chronic kidney disease. Atherosclerotic cardiovascular disease and type 2 diabetes mellitus risk arises early from the common soil. That is, the predisposing factor remains the same for the type 2 diabetes mellitus and the cardiovascular disease. And the cardiovascular disease, that is, the cardiovascular death account for 2/3 of all that death in type 2 diabetes mellitus. So atherosclerotic cardiovascular is causing 2/5 of all death which has been occurred in diabetic population. Coming to the cardiovascular risk in patient of type 2 diabetes mellitus, so we have seen that cardiovascular disease is quite common in type 2 diabetes mellitus. So there are multiple factors which is responsible for it, which include dyslipidemia, hypercoagulation state and the platelet activation, metabolic dysfunction, and environmental pollution. Endothelial dysfunction, arterial stiffness, inflammation, and oxidative stress are the other common proposed factor. Physical activity, poor diet, smoking, and obesity. Ultimately, all these conditions leads to the development of the cardiovascular disease in those patients who are having a type 2 diabetes mellitus. Hazard ratio for the vascular outcome in people with a type 2 diabetes mellitus versus those who are not having a diabetes at baseline based on the analysis of huge population has been done. Here we can see that overall the coronary heart disease is quite common. That is, the hazard ratio is in the favor of those population who have a diabetes. Similarly, the coronary death, non-fatal myocardial infarction, stroke subtypes, whether it is ischemic or unclassified or hemorrhagic, almost all such complications are quite common in diabetic population as compared to the non-diabetic population. So cardiovascular risk category in the patients, very high risk is usually those patients who have a diabetes mellitus and established cardiovascular disease, or those who are having a target organ damage or 3 or more risk factor if the patient is having, or early onset of type 1 diabetes mellitus, that is a long duration, more than 20 years of presence of the diabetes. High risk includes patient with diabetes mellitus duration of more than 10 years without target organ damage plus any other risk factors. And moderate risk includes the young patient, type 1 diabetes less than 35 years, type 2 diabetes less than 50 years with diabetes mellitus duration of less than 10 years without other risk factors. Coming to the direct and indirect action of SGLT2 inhibitor and the benefits which are occur in the cardiovascular, renal, and the metabolic parameters. So we can see that with the use of the SGLT2 inhibitor, there is a decrease in the cardiac preload, there is decrease in ventricular remodeling, atrial remodeling, systolic dysfunction, diastolic abnormality, and there is decreased possibility of the fibrosis. Similarly, the other benefit associated with the SGLT2 inhibitor includes decreased uric acid, decreased body mass because of the loss of the fat mass, especially the intra-abdominal fat mass has been lost. There is increased level of lipolysis and triglyceride level. There is decreased glucose and insulin resistance. There is increased natriuresis and decreased albuminuria and decreased fluid retention. Overall, the beneficial effect has also been demonstrated in the improvement in the endothelial function. There is a decrease in the systemic blood pressure, decrease in the fluid load, and increase in hematocrit. Ultimately, the beneficial effects is because of the decreased inflammation, decreased oxidative stress, and decreased uh, sympathetic nervous system activity has been responsible for all this beneficial effect. So now coming to the empagliflozin causes improvement in achievement of the systolic goal blood pressure in the patient which are having a persistent hypertension. So this slide has been generated from the EMPA-REG outcome, and it has demonstrated that as compared to the placebo, the chances of good BP control is significantly higher in patients who has been treated with empagliflozin. The odd ratio is 1.69, p-value is less than 0.001. So systolic blood pressure goal achievement in the patients of resistant hypertension, type 2 diabetes, and cardiovascular disease, empagliflozin used for 12 weeks associated with significant reduction of the systolic blood pressure. There is 52% risk of the new onset obstructive sleep apnea with empagliflozin treated group as compared to placebo in patient of type 2 diabetes mellitus and cardiovascular disease. So this data again generated from the EMPA-REG outcome, and it has demonstrated that those patients who has been treated with empagliflozin, there is significant chances of less development of obstructive sleep apnea as compared to the placebo. Coming to the empagliflozin associated with decrease in the uric acid level. So there is decreased chances of development of gout or need for any anti-gout medication. The effect of empagliflozin either 10 or 20 milligram doses pooled study has demonstrated that as compared to placebo population, the uric acid has been significantly low in this population. And the time of onset of new gout or anti-gout medication has been significantly less in those patients who has been treated with the empagliflozin. So now coming to the third aspect, that is the empagliflozin in the type 2 diabetes mellitus and atherosclerotic cardiovascular disease with various cardiovascular disease manifestation. So empagliflozin may also decreases the risk of arrhythmia and sudden cardiac death in the patient of atherosclerotic cardiovascular disease and type 2 diabetes mellitus. Again, this data has been generated from the EMPA-REG outcome. So overall, the ventricular arrhythmia is significantly less in the empagliflozin treated group, and similarly, the sudden cardiac death is significantly less in the empagliflozin treated group. P-value is statistically significant for both the parameters. In patients with type 2 diabetes mellitus and atherosclerosis cardiovascular disease, EMPA-REG outcome has demonstrated that there is a clear benefit with those patients who has been treated with the empagliflozin. There is decreased risk of the cardiovascular death. So overall study population, there is 30% risk reduction. And when the subgroup analysis was done with the Asian population, it has been found that there is a 56% risk reduction was there with the cardiovascular disease in Asian patients. So empagliflozin has shown constantly decrease in the risk of the cardiovascular disease in the patient of atherosclerotic cardiovascular disease and type 2 diabetes mellitus, regardless of the cardiovascular disease manifestation. So whether the patient is having a single vessel cardiovascular disease, multivessel cardiovascular disease, whether the patient is having a already history of cardiovascular bypass graft or prior history of myocardial infarction, everywhere the cardiovascular disease risk reduction is significantly higher in the empagliflozin treated group. Coming to the empagliflozin has consistently reduced the risk of cardiovascular death in the patient of atherosclerotic cardiovascular disease and type 2 diabetes mellitus, regardless of the cardiovascular disease manifestation. Cardiovascular disease risk reduction with empagliflozin in patient with stroke, peripheral artery disease, heart failure, or atrial fibrillation. Everywhere the beneficial effect has been demonstrated in those patients who has been treated with a cardiovascular uh, uh, for any of the cardiovascular diseases risk. Beneficial effects has been demonstrated with the use of the empagliflozin. Now coming to the effects of empagliflozin on heart failure outcome, these are the recent two study which has been available for heart failure with reduced ejection fraction and heart failure with the preserved ejection fraction. So emperor reduced and emperor preserved. These are the two studies which are available. And the cardiovascular death or hospitalization for heart failure, the beneficial effect has been demonstrated in emperor reduced study. Here we can see that the uh, hazard ratio is hazard ratio is 0.75, which is ranging from 0.65 to 0.86. For emperor reduced, it is 0.79. For emperor preserved, time for first hospitalization for heart failure is significantly reduced in those patients whether they are having a reduced ejection fraction or whether they are having a preserved reduction fraction. Similarly, the time for cardiovascular death reduction has been demonstrated, but not up to statistically significant level. The total first and recurrent hospitalization for heart failure, the beneficial effect has been demonstrated in both the group. That is, those which who are having a reduced ejection fraction and those who are having a normal ejection fraction. So, in both the parameter, there are significant beneficial effect in terms of the reduced hospitalization for heart failure has been demonstrated. Now coming to the Emperor Preserve is the first study in heart failure with preserved ejection fraction to meet this primary outcome. Various other study has not shown the beneficial effect in terms of primary endpoint, that is the hospitalization for heart failure or cardiovascular death. But empagliflozin has the only study still date which has demonstrated the beneficial effect in terms of the primary outcome. Various other study which has been done either with the candesartan versus placebo, irbesartan versus placebo, pridogrel versus placebo, spironolactone, or digoxin versus placebo, they fails to demonstrate the beneficial effect. So probably this is the first landmark study and may create the breakthrough in the management of CAD patient, that this particular molecule reduces the cardiovascular death and the hospitalization for heart failure. And that is why we are discussing this particular molecule in today's discussion. So recently, FDA grants the approval for this empagliflozin for the therapy of heart failure with preserved ejection fraction. So this particular molecule can be used to reduce the risk of the cardiovascular death plus hospitalization for heart failure in adult population who are having a heart failure and reduced ejection fraction. So coming to the clinical consideration for anti-diabetic agent, SGLT2 versus DPP4 inhibitor. So glycemic efficacy of Sglt2 inhibitor is stronger in Asian population when compared with the white population. Here we can see that the Sglt2 inhibitor in Asian population causes reduction of HbA1c of almost up to 0.96%, while in white population it causes HbA1c reduction of 0.64%. Here we can see that the baseline HbA1c is comparable, that is 8.2 in both the population. Similarly, the DPP4 inhibitor has also been demonstrated to have a slightly more beneficial effects as compared to the Caucasian population. So, clinical consideration for anti-diabetic agent. Uh, Here we have seen that the SGLT2 inhibitor virtually does not causes hypoglycemia. The weight loss is the additional advantage with this particular molecule. Cardiovascular beneficial effect has been demonstrated with the empagliflozin and canagliflozin only, but in terms of reduction of heart failure, almost all molecule, whether it is AMPA, DAPA or CANA, has shown the beneficial effect. Unfortunately, we do not have any data available with the remogliflozin because no trials has been done. for atherosclerotic cardiovascular disease or congestive cardiac failure. So dapagliflozin, we do not have any data. Renal beneficial effect has also been demonstrated that progression of diabetic kidney disease has been halted or it can be reduced with the use of the CANA, AMPA or dapagliflozin. And renal dose adjustment is definitely required in those patients who have renal impairment, but the beneficial effect has been demonstrated with all the three molecules. Now coming to the HbA1c reduction in drug-naive patient, empagliflozin versus sitagliptin and glimepiride. So greater HbA1c reduction has been shown with the empagliflozin versus sitagliptin and glimepiride in patients of type 2 diabetes mellitus. The incremental reduction in HbA1c was increasing baseline HbA1c greater with the empagliflozin versus sitagliptin or glimepiride. So this molecule is more stronger. Empagliflozin has also shown effective glycemic management and cardiovascular protection as compared to DPP-4 inhibitor. Here we can see that the effective glycemic management is empagliflozin, the cardiovascular protection, there is 41% lesser risk of hospitalization for heart failure and 48% lesser risk for cardiovascular mortality when those patients who has been treated with the empagliflozin as compared to sitagliptin. Now compare empagliflozin versus sitagliptin in the early stages of type 2 diabetes mellitus without current cardiovascular disease complication. So superior effect on the cardiometabolic biomarkers like uric acid, high density lipoprotein cholesterol, ketone body and insulin sensitivity has been demonstrated with the use of the empagliflozin. Early SGLT2 inhibitor may be more beneficial than DPP4 inhibitor even in patients of early stages of type 2 diabetes mellitus without current cardiovascular disease complication when considering the primary preventive strategies for cardiovascular disorder. Now coming to the effect of empagliflozin on the insulin requirement. Long-term decrease in insulin requirement has been demonstrated with the empagliflozin use in the patients of type 2 diabetes mellitus. Whether it is a new initiation or significant increase in insulin dose, both has been significantly reduced. And this data has been generated from empiric outcome. The new initiation of insulin is significantly reduced. Similarly, the dose of insulin is also significantly reduced in those patients who has been treated with empagliflozin, and both these data are statistically significant. So the beneficial effect, how beneficial is the effect, we can see from this slide. For all 100 patients which has CAD and type 2 diabetes, which has been treated with empagliflozin for 3 years, there is the additional long glycemic benefit has been demonstrated. For this, 9.8 cardiovascular events can be prevented, 8.5 cardiovascular disease event can be prevented, 3.4 acute kidney injury or acute renal failure or hyperkalemic event can be prevented, 12.9 insulin requirements can be prevented, and 5.1 additional systolic goals is achieved in resistant hypertension, 5.5 less chances of edema or new obstructive sleep apnea, and 3.4% total additional life year has been gained. So now coming to the pharmacoeconomic and guideline recommendation for this particular molecule. Cost effectiveness of empagliflozin versus canagliflozin, dapagliflozin or standard of care in patient with type 2 diabetes mellitus with established cardiovascular disease. So empagliflozin plus standard of care was projected to dominate the cana plus and it has been found that it is highly cost effective therapy compared with the dapagliflozin. So this is the recommendation of ADA 21. It suggests that the SGLT2 inhibitor atherosclerotic cardiovascular disease, the beneficial effect has been demonstrated with the empagliflozin, canagliflozin. For heart failure, the beneficial effect has been demonstrated for all the three molecules, that is empagliflozin, canagliflozin, and dapagliflozin. And progression of diabetic kidney disease, the beneficial effect has been demonstrated again with the canagliflozin, empagliflozin, and dapagliflozin. So for prevention of atherosclerotic cardiovascular disease, we should use only empagliflozin or canagliflozin. But for other benefit of cardiovascular or diabetic kidney disease, we can use other gliflozin also. So to conclude, coronary artery disease is one of the major cardiovascular disease burden in type 2 diabetes mellitus. Direct and indirect action of SGLT2 inhibitor through sympathetic nervous system or other oxidative pathway or inflammatory pathway likely to produce cardiovascular and renal and metabolic benefit. Empagliflozin in recent study has shown favorable effect on cardiovascular risk factor and BP and obstructive sleep apnea and uric acid. Empagliflozin has consistently reduced the risk in cardiovascular death in patients of type 2 diabetes mellitus and cardiovascular disease, regardless of cardiovascular disease manifestation. Empagliflozin is effective and proven therapy irrespective of left ventricular ejection fraction. And this is also effective for glycemic management and cardiovascular protection as compared to DPP-4 inhibitor. Thank you.